Hi, my dear friends. It's a pleasure to meet you in this part 5 and final part of pulmonary pathology. Here I'm going to start with a very interesting question. Many people ask me how to count mitosis per millimeter square. So let us start with that and then continue our journey with the neuroendocrine tumor. And a lot of molecular stuff is going through the neuroendocrine tumor. We will go through that. And I thank Dr. Natasha from Memorial Sloan Kettering and the USCAP 2021 conference for updating the molecular events that are not widely published right now. And they are not into use right now, but knowing them is good for future. And I will end it up with molecular markers that are used or that are of practical importance in lung cancer management. And finally, I will summarize the most of the stuff we saw in all these part 5. I hope you enjoyed this presentation and thank you very much for your support and love towards me.
Counting mitosis. Remember I told you, and many people are jittered how to count per millimeter square. It's very, very easy. Take your eyepiece. For example, here I have taken the eyepiece with a 10x and the number here, field number is 18. And you have to know the three numbers: eyepiece magnification 10, eye field number 18, and what is the objective magnification. Usually mitosis we count it under 40x, so it is 40x. When you have these three numbers, you have to calculate the field diameter. Field diameter is equal to field number divided by objective. Field number is 18, objective is 40. So this field diameter you have to get it. Okay, again field number divided by objective power 0.45. When you have this value, all the books including the CAP has a table that talks about when the field diameter is this, how many number of fields you have to calculate per millimeter square. Okay, with this eyepiece with 40x, I have to calculate 6 fields for 1 millimeter. So for 2 millimeters, I have to count 12 fields. So it is very, very easy. Forget about this field area. Field area is calculated by pi r square, but when you do know the field diameter, that is more than enough. Okay, so field diameter and the number of fields per millimeter square. This is the easiest way to count it per millimeter square. Why it is important? All the tumors now they are changing the criteria into millimeter square. It can be either 2 millimeter square or 1 millimeter square or 10 millimeter square. It is coming into millimeter square. They are bringing it mainly because the fields are different in various microscopes and in various digital microscopes. So to artificial intelligence, if they calculate per millimeter square, that will be easier. That's why they are bringing it. So this is an example of normal, less than 5 cells confined within the basement membrane. And here it is hyperplastic cells. They are neuroendocrine cells proved by synaptophysin, and they are seen within the basement membrane. Okay, that basement membrane is very, very important. More than 5 cells beyond the basement membrane, but less than 5 millimeters. So this is tumorlet. Carcinoid more than 5 millimeters beyond the basement membrane. These are the three patterns: nested, trabecular, and frequent rosettes, spindle cells, glandular, and oncocytic. I want to thank Dr. Natasha because I took it from her Twitter page. This is the 2015 classification: typical carcinoid, atypical carcinoid, small cell or large cell neuroendocrine tumor, and combined tumor. See, in other organs, we are getting carcinoid, neuroendocrine tumor itself, grade 1 carcinoid, grade 2 atypical carcinoid, grade 3 high grade, and neuroendocrine carcinoma apart from grade 3. That pattern is not come in the lung. Okay, and K67 is not mandatory. The net grade 3 is not introduced formally in the lung. So you have to remember that uniform net classification for GAT and pancreas, you cannot use it in the lung, but I am 100% sure in future it will come. Case number 19, core biopsy. think I have one more case. Slide check, Ashwini.
All good, sir.
Super, ma. Any questions, ma?
No new questions, sir.
Super. So this is the core biopsy with extensive necrosis. Aha, dark blue cells, not a good sign. Dark blue cells. So go to the high power in those areas. These are small blue cells. Okay, but lymphoma is definitely one of the differential diagnosis. I will enable the digital. See the crush artifact. When you see this much of crush artifact with the nuclear molding, you have to think of small cell carcinoma. Lymphoma won't show this much of crush artifact with nuclear molding. So this is diagnostic. Okay, see the nuclear molding. They may look like a spinal cord. Okay, spinal bodies. So these are nuclear molding. So this is a small cell carcinoma. Pattern 5, nuclear molding and increased number of apoptosis. Mitosis you cannot appreciate because of the dark hyperchromatic nuclei. Small cell carcinoma, also known as wart cell carcinoma, because they may resemble warts. Less than 3 times the lymphocytes, finely dispersed chromatin, scan cytoplasm. High grade nuclear atypia and mitotic and apoptotic rates are very increased. Very fragile nuclei. Okay, see the crush artifact. Destructive sheets, no architecture. There is a paradigm shift in the approach to small cell carcinoma in the lung. Previously, they used to tell no need to do immunohistochemistry. Now, you have to do the immunohistochemistry because of the differential diagnosis. In smokers, basaloid squamous cell carcinoma and SMARCA4 deficient undifferentiated tumor is the differential diagnosis. In the non-smokers, nut carcinoma, crushed carcinoid, Ewing's, metastatic Merkel cell tumor, and the lymphomas. And you have to do immunohistochemistries. But rule number 2, you should not depend mainly on immunohistochemistry. You have to take H&E along with the immunohistochemistry as a marker for diagnose small cell carcinoma. And this is the molecular event in small cell carcinoma. They are molecularly divided mainly into 3 types: ASCL1, NeuroD1, POW, POU. Remember, there's a new marker for POW, POW2F3, and YAP. These are the 4 markers for small cell carcinoma. And this is the composite picture of various immunohistochemical markers. This POW1, instead of WOW, you say POW. POW1, it's POU. POW just make you to remember. Okay, this is negative in well differentiated neuroendocrine tumor, whereas it is positive in minimal neuroendocrine differentiation. See here, synaptophysin is positive here, whereas POW1 is negative. Synaptophysin is negative in minimal neuroendocrine tumor, whereas POW2F3 is positive in minimal neuroendocrine tumor. So if you do INSM1 and POW, you will cover all the neuroendocrine tumors. The last case, case number 14, right lung mass, solid mass, lobectomy, solid tumor, again airway and big blood vessel. Let us go to slide number 14. Slide check. Ashwini, poor Ashwini. I'm not allowing you to. Are you doing all right, Ashwini?
The slides are clear, sir.
Super, ma. No questions?
So no new questions.
Super, ma. So extensive necrosis, and see the organoid pattern. Okay, you have to think of large cell neuroendocrine because there is extensive necrosis and the tumor cells are arranged in a organoid pattern in the low power. Then we will go to hyper. See the moderate amount of cytoplasm. How will you determine the amount of cytoplasm? By looking at the distance between the nuclei. Okay, so if it is less cytoplasm, nuclei will be more crowded. Here they are more spaced. So this is more moderate amount of cytoplasm, and look at the nucleoli. It's not focused very well. So you can look at the prominent nucleoli. Extensive necrosis, nested pattern, prominent nucleoli. You have to do markers to differentiate large cell neuroendocrine carcinoma from other large cell carcinomas. CK7 is nicely positive. Synaptophysin is nicely positive. This is a old case of ours. I have not repeated the INSM1, and we don't have the POU, POU F2. We don't have that marker. So this is a large cell neuroendocrine carcinoma. So this brings to end of the cases, and a few points to be discussed about molecular subtyping of neuroendocrine tumor. There are 4 types in carcinoid. Just remember, there are 4 types in carcinoid. There are 3 types in large cell neuroendocrine carcinoma, and there are 4 types in small cell carcinoma. So 4 for small, 3 for large cell, 4 for. They are not in practice now. They are all coming up. I just want to keep you updated. And these are all the material I got from USCAP meeting in this March 2021. They are not even published widely. So why we have to know these markers? Because therapeutic implications is that. That is the one point you have to remember. Any molecular change, it should have either diagnostic value, prognostic value, or theranostic value. If there is no value for these 3, there is no need to remember that marker. Oh, one more last case. Case number 6, right lung nodule, 2 centimeter in a 54-year-old, 55-year-old female. Sorry for lying to you that the previous slide was the last case. Slide 6. Slide check. Ashwini.
Yes, sir.
So no normal lung tissue, more fibrous tissue, and tumor. This looks more papillary, isn't it? So can it be adenocarcinoma with the papillary pattern? In the lung, first you have to describe whether it is small cell or non-small. This is non-small cell. Is it squamous or adeno? This is adeno. And then subtypes. Is it lipidic? Is it mucinous? Is it non-mucinous? Is it papillary or solid? This looks like acinar and papillary. But the first question you have to ask is it primary or metastasis? Okay. So we cannot say that with this slide. So let us go back to the presentation. TTF negative. If it is primary, TTF has to be positive. CK7 strongly positive. Can it be TTF negative, CK7 positive lung primary? Yes. CD20 negative, CK20 negative, no problem. ER strongly positive. Lung carcinomas are not this diffusely positive for ER. Okay, when ER is positive and CK7 is positive, you have to think of breast. Okay, PR strongly positive, and so this is metastatic from breast carcinoma. In metastasis, history holds the key. You have to remember, history solves the mystery. And now we have the PET scan and IHC to help us. But before getting the IHC, you have to get the history and radiological findings. Then only you have to go for IHC. Final 5 minutes for molecular testing for non-small cell lung carcinoma. Previously, it is non-small cell and then adenocarcinoma and squamous cell carcinoma. Now we have this many types of mutational changes in adenocarcinoma. So what is the treatment algorithm? Adenocarcinoma are all non-smokers. Okay. Look for actionable target. What are the possibilities? Possible treatment, surgery, and medical oncological treatment. In the medical oncology, traditional chemotherapy or targeted therapy or immune modulators. So these are all the 3 possibilities: targeted therapy, traditional chemotherapy, and immune modulators. Okay, pembrolizumab is the immune modulator, this P. When the driver mutations, actionable targets are present, we have to give for personalized tailored treatment or targeted therapy. When the actionable targets are absent, we have to go for PDL1. When it is more than 50%, we have to either give anti-PDL1 or pembrolizumab or along with platinum-based chemotherapy. When there is no PD-L1 positivity, we have to go for conventional chemotherapy with platinum-based therapy. Squamous cell carcinoma, no driver mutations. It's only PD-L1. When it is present, anti-PD-L1. When it is not present, conventional chemotherapy. That's the concept you have to remember. And what are all the markers we do for adenocarcinoma and squamous cell carcinoma? For adenocarcinoma, we do all the markers: EGFR, ALK, ROS1, BRF, NTRK, MET, RET, and then immune modulator PD-L1. Whereas in squamous cell carcinoma, we do the PD-L1, and for non-smokers or in cases if it is needed, we do the other markers. I have put the technologies here. FISH is used for ALK, RAS, and RET. IHC used for PD-L1. All others are diagnosed by multiple parallel sequencing or massive parallel sequencing or next generation sequencing. And these are all the medicines available against these markers. This is very important. If they don't have medicine, there is no use for looking this. Remember the 8 markers. So to test these markers, we have to carefully handle the tissue. If it is cytological tissue, make the cell block, get into formalin fixation and paraffin embedded blocks, or from direct smears. After diagnosis, you scrape the cells and then use its cell scrapers. For liquid based preparation, cell scrapings you can use for ICC or FISH. When it is biopsy, we have to handle it very carefully. There is a beautiful article in Archives of Lab Medicine, Pathology and Lab Medicine. Do more with less. Number 1, this you have to practice from tomorrow in your lab or from next week when you go to your hospital. When there are 2 biopsies, don't embed in the same block. Embed in the 2 different blocks, because during leveling we may lose tissue from 1 block. So level it in, give it in 2 blocks. Okay. And then the common procedure, we get 2 sections for H&E. After that we order for IHC. After that we order for molecular. So trimming, 2 unnecessary trimming is there, and you all know trimming leads to loss of tissue. So for all lung cancers, get 8 to 10 slides, unstained slides. Stop to you stain for H&E, and the remaining you use depending upon the H&E, so that there is no recuts. It's all done in the first go. PD-L1, a word about PD-L1 because they may ask you in the exam. It's a membranous marker. It is negative, positive less than 50%, positive more than 50%. The intensity doesn't matter. Here it is weak intensity, here it is strong intensity. It doesn't matter. Okay, so whether it is more than 50% or less than 50% is very, very important. One word of caution: the alveolar macrophages you see in the adjacent lung can be positive for PD-L1, or there may be some alveolar macrophages or tissue macrophages infiltrating along with the tumor, that you have to be careful. Macrophages will be less intensive, whereas tumor cells will be more intensive. So whenever it is positive, look for changes associated with the tumor. These are all the macrophages and these are all the tumor. I want to thank Dr. Sanjay for giving this beautiful slide. This is a membranous positive. Each word is important. Okay, the clone we are using or we should use is PD-L1 22C3. This is FDA approved. This has to be positive. Number 1, membranous positivity. Number 2, any intensity. Number 3, beware of macrophages. And number 4, report the percentage positivity. If it is more than 50%, then only anti-PD-L1 will be effective. This is the most recent one. What are the biomarkers beyond PD-L1? This is for theory exam. Tumor mutational burden signatures, major histocompatibility complex 1 and 2, CD8 positive T cells, multiplex immunoprofiling or spatial profiling, and protein correlates of genomic biomarkers with STK11, LKB1, KEAP1 or SWSNP, SNF pathway members. So we have to handle the sample very, very carefully. When the sample is ample, no issue with the tissue. But when the sample is small, we have to be very careful in handling. And finally, how do you know whether the therapy is effective? So post chemotherapy, they will do the surgery. And this is a nice paper that gives recommendation, 11 recommendations for the assessment of lung cancer resection after neoadjuvant therapy. And the main takeaway point is 3 histological features should be assessed. Okay, and they have to be given percentage, and it has to add up to 100%. Viability of tumor, necrosis, and stroma with the inflammation. We have to give the percentage, and the inflammation has to be graded into mild, moderate, and severe. And when the viable tumor is less than 10% after post chemotherapy, the prognosis is very good. That's why we have to assess this. Coming to conclusion, the 5th edition WHO, secondary, primary, epithelial, neuroendocrine, mesenchymal, hematolymphoid tumors of ectopic tissue in the epithelial, glandular, squamous, adenosquamous, large cell, sarcomatoid, salivary gland type, others. Lung pathology, 6 patterns: acute lung injury, fibrosis, cellular infiltrate, alveolar filling, nodules, and minimal change. And 3 things you have to remember: handling the cytology and the transbronchial biopsies, immunohistochemistry, and molecular studies. FNAC, smear, ICC, liquid-based cytology, cell block, IHC, molecular. For molecular workup, you have to be handling them very carefully, as I mentioned. IHC, primary or CK7, TTF1, napsin, P63 or P40, TTF1, napsin for adenocarcinoma, P63, P40 for squamous cell carcinoma, INSM1 for neuroendocrine marker. Remember the POU, POU, F2, all negative, and when vimentin is positive, it is null cell IHC type. Molecular, for targeted therapy, for adenocarcinoma, we do EGFR, BRAF, ALK, ROS1, NTRK, MET, PET, RET, and PD-L1. For squamous cell carcinoma and above negative adenocarcinomas, we give treat only PD-L1, and whether it is positive or negative, depending upon that, we give only chemotherapy or chemotherapy plus pembrolizumab, which is anti-PD-L1. Thank you very much. I know I overshoot the time allotted to me, but since I have to discuss the slides in a new manner, I thought it is worth spending.